Hey guys, welcome to another video of topic discussion. Today I'll be talking about diabetic foot infection. So as a podiatrist, diabetic foot infection is one of the most common things that we're consulted for. So for example, when a patient comes in with a foot infection, being a diabetic, the emergency department will consult podiatry and we'll go down to the ED and evaluate the patient. So the first thing we do is we get the HPI, history of present illness, figure out what's going on with the patient. Has there been any trauma to it? Has there been any precipitating events? Has there been any extraordinary things that kind of led up to that moment? Afterwards, we will get the patient's history, medical history, social history, family history, and hospitalization or past surgical history. So after taking HPI, you want to do the review system just to see if there's anything, any abnormality occurring with the patient. And then you would proceed on with the physical examinations. And you start by doing the vitals. The thing that you want to focus when you're looking at vital is whether or not patient exhibits certain inequalities of source criteria. There's 4 things in source criteria that you have to pay attention to. Temperature, the patient has to have less than 36 Celsius or 98.6 Fahrenheit. Temperature should not exceed 38 Celsius or 100.4 Fahrenheit. Second criteria is white blood cell count, less than 4,000 or above 12,000. Third one is respiratory rate, less than 20, or it's PaCO2 value less than 32 millimeter of mercury. The fourth criteria is pulse, which has to be less than 90. Now there are other criteria other than thirst criteria to kind of indicate whether or not patient is going to get infection. And recently the SOFA criteria, SOFA or QSOFA for a quick version, which has a different criteria, kind of similar one, is where the mental status of the patient using the Glasgow Coma Scale, and then the systolic blood pressure less than 100 or respiratory rate greater than 22. So there's a different way basically to kind of quickly assess whether or not patients is going to progress through a pretty severe problem. So after you do that, you start with your 4 basic dermatological, neurological, musculoskeletal, and vascular examination. So in dermatological, you want to basically describe the wound and kind of examine what's going on with it. First thing is kind of look around the wound, starting from the outside, working towards the inward. Are there any lymphangitis, streaking, or redness around the wound margin? Now, if it's less than 2 centimeters of erythema on the wound margin, technically based on the IDSA classification, it will be considered mild. But if it's more than 2 centimeters, that'll be moderate. And then if it has more than 2 centimeters, along with at least with a systemic sign of infection, that'll be considered severe infection. And depending on the classification of that, the patient will get different treatment. So you look at the wound around it. Is it a well-defined margin? Is there hyperkeratotic? You're moving closer to the wound bed. Now, is the wound bed necrotic? Is it granular? Is it fibrous? Or a mixture of fibrogranular wound? And oftentimes, I think wound bed is kind of fibrogranular. A lot of these diabetic foot infection. You want to measure the wound and see if it probes to bone. And if it probes to bone, but based on the classic art literature, Grayson and Lavery, kind of indicates that you have a high suspicion for bone infection. You describe the wound, the depth, the wound bed. You want to see if it has any mild odor, potentially indicating gas, or it does have, what kind of color is it? Is it greenish tinge? Is there any drainage? What kind of drainage is it? Is it serous or sanguineous, or just purulence? If it's purulence, then it's kind of indicating a staph infection compared to a strep, where it doesn't really have much of that purulence going on. So after you describe that, that's basically done with the dermatological examination. Of course, you want to examine other part of the foot and the lower extremity. Moving on to vascular, you want to check for pulse, obviously, DP and PT, and whether they're strong. In certain cases of foot infection, they may end up with a bounding pulse because of the inflammation that's going on in the foot. But oftentimes, these diabetic patients, with their comorbidities, they will also have sclerosis of the vessels, and sometimes you will not be able to feel it. So if that's the case, you would later on order non-invasive vascular studies like segmental pulse pressure studies, ABIs, TBIs, or even Doppler. And one thing to keep in mind is that the reason vascular is so important is because if the patient does require surgery, the patient needs to close out wound. Vascular is a huge factor determining whether or not, a predictor whether or not a patient can heal the wound. The next examination you will do is neurological, and you just want to see if the patient has any sort of neuropathy, because a lot of these diabetics have associated neuropathy, and that could have resulted in the foot infection in the first place. So after you're doing that examination, you can move on to the musculoskeletal examination, and you want to see if the patient have any sort of equinus that may have resulted in that diabetic foot ulceration, and that could also determine what kind of surgical procedures you would do. Just also checking range of motions of the ankle and pedal joints, and if there's any pain or limitations, kind of give you a sense how severe the illness is. So after you're done with the physical examination, you want to go ahead and order additional labs or studies. First one is radiograph, and X-ray is an excellent way to kind of gauge the severity of the problem. If you take an X-ray radiograph, and if there's potentially gas, you can detect that early on, and that will allow you to kind of move on to the surgical option right away, and make sure you catch that early on. Since gas is an emergent case, you probably want to take this surgery as soon as possible. Second, and then again, like I talked about before, you could also order advanced imaging like MRI or CT. Next one is CBC with differentials. You want to see if there's any sign of infection and the body's appropriately reacting to the infection, potentially with a neutrophil band shift, the value of the neutrophil, and all that stuff. Next is CMP. You want to see if there's any electrolyte imbalance, if the patient has proper kidney function, especially with diabetics. There might be some, not fully functioning kidneys, so that could also determine whether or not you want to do a contrast when you're doing advanced imagings. You also want to do coagulation studies. Again, if you want to take the patient to surgery, you have to make sure the patient can heal that surgical incision. Inflammatory markers, CRP and ESR, and there's literature showing that CRP at a threshold mark of 3.2 kind of means that you can't really heal that. It sounds of a bone infection. And ESR above 70, based on Kaleta et al., also indicates that you have a most likely probable bone infection. You want to also go ahead and order non-invasive vascular studies, ABIs, TBIs, Doppler, or like I mentioned earlier, segmental pulse pressure. You also want to order MPO status potentially if you want to take the patient to surgery. So after you order those, there are other things that you could order based on the patient population. If the patient has a history of drug abuse, you could also order a drug screening to see if there's any toxins in the body. If the patient has a history of homelessness and you feel like the patient is malnourished, you could also order an albumin level. And there have been literature showing you that in order for a patient to heal a wound properly, you need to have a certain albumin level, specifically 3.5. You could also order EKG preoperatively if you're going to take the patient just to make sure the heart's functioning fine. So after you order these, you look at the radiograph and you make a decision whether or not you want to admit the patient to the hospital or send them out treated outpatiently. So you would most likely send the patient out if the patient has very simple soft tissue infection, just a cellulitis with a very, very shallow ulceration. And you would then treat it with an antibiotic ranging from 1 to 2 weeks. And you would admit the patient if there is a complex comorbidity associated with the patient, if the patient requires an IV antibiotics, and if you are uncertain whether or not patient can follow the protocols that you provide for the patient outpatient care, then you would admit the patient. And after you admit the patient, you would basically dispense the antibiotics depending on the images that come on later on, or the result of the study that come later on. And if the patient requires surgery or IND, incision and drainage of the infected area, you would take it to the surgery, and you could do multiple INDs and make sure you get a clear, clean area of wound, and then basically you would afterwards take the patient, transfer the inpatient to an outpatient after you make sure that there is no existing infection, along with antibiotics prescription and follow-up care in the outpatient clinic. So that's how you generally manage a diabetic foot infection. Hopefully this video helped you with kind of giving you a sense of how to do that. I'm just practicing how to do this and saying out loud because I have a CRIPS interview, as you guys know, for podiatry residency match. So if I missed anything or if there's some confusion of information, please let me know in the comments below. And thanks for watching, and remember to subscribe.